Rebuild is a research program consortium that was started in 2011. It's a 6-year program. We decided that in the health systems area we would like to focus particularly on health systems as they emerge from conflict. And so we've taken a lens, a historical lens, to try and understand what key decisions are being made in relation to health systems. And the areas we've focused on are health financing and human resources, but also we have a gender and equity going through, and we link with the RINGS program that was developed with 3 RPCs out of this program. We work in Sierra Leone, which is a more recent country coming out of conflict, and northern Uganda, even more recent. Cambodia gives us the very long lens, and we call Zimbabwe a post-crisis country rather than a post-conflict one, but we are looking at health systems developments there too. And we have a number of affiliates to the Rebuild project, and some of those bid for funds, and so we've expanded our countries, so we now include Côte d'Ivoire, Gaza, northern Nigeria and Sri Lanka. The UK partners are for the Liverpool School of Tropical Medicine that I'm representing, and Nick, and Queen Margaret University that Sophie is from. Our theory of change, obviously we're looking at the research, but in order to ensure that this gets adopted, we have our research uptake process, and we've been able to do a lot of capacity building, which we'll talk about in a moment. So in thinking about this particular presentation, I'll move to the next slide, the contributions to the health systems framework. We thought that we could contribute the following ideas. The first thing is the importance of the policy context, which probably you would look at anyway, but we're looking at it particularly from a historical perspective. So for example, if you look at contracting out of services, in Cambodia we see that they started with the public sector, they moved into NGO contracting, and that's quite common in post-conflict. And now they're moving back into trying to take control through their special operating areas system that we've been studying. Whereas in Sierra Leone, they took the decision very early on not to contract out services to NGOs and retained much more ownership of the service delivery. A second area that we would look at are the actors and power, and again, normally you would probably look at that in any framework. But the thing perhaps is slightly different in the post-conflict situation is the speed with which those actors and the power might change, particularly in that early post-conflict period, with perhaps local leadership vacuum, with powerful agencies coming in and taking over, possibly not really understanding the context. And another impact of that will be if you have the situation like northern Uganda, where NGOs employed many people, then that skews the labour market. So we'd want to look at how actors and power changed from the post-conflict, initial post-conflict period, and the impact that that had. We're now a lot of talk about health systems resilience, the recognition that there's a need for flexibility in health systems to withstand shocks. And one area that we found particularly important, mostly from the work in northern Uganda, is whereas we may look, when we're looking at human resources, we may look at the numbers and types of staff. Here we're looking at the characteristics, which are the types of staff which are more likely to stay and be able to work effectively. The time is coming. So gender and equity, I think the strong thing there is some analysis we've done in terms of policy analysis, obviously in maternal health, gender is taken into account, but other areas is not, and so that would need to be brought in. And the final area is the social contract, that the relationship between state and users is going to very much affect the effectiveness of health services and needs to be understood when designing them, but also the improvement of the health services and employment of health workers actually might improve that relationship. So these are areas that we would want to include in the programme. Just finally, I'd like to say a little bit about the approach. We have focused a lot on capacity building, and what this has been able to do is allow us to have people on the ground, such as Sierra Leone, who are responsive to the local context, understand it, and they can, in a sense, there's more balanced power relationships because they have done the research, they understand the context, they can actually speak, they can articulate the research findings in an informed way that would redress some of these power balances. And finally, the issue of the benefits of a multi-project country program, where we're looking across, and at the moment we're drawing together lessons from all of the different projects, but also a multi-partner one. So we've got partners of our own, the affiliates, and we're working with PhDs, and bringing all of that together brings a much richer set of findings on health systems in post-conflict. Thank you.